So thank you very much all. We'll just go through the slides now. And again, if you're not presenting, please go on mute. So Paxlovid consists of 2 drugs, one of which I find very difficult to pronounce, but I'm going to give it a try. Nirmatrelvir, or as all the cool kids are calling it, PF073213332, and ritonavir. Nirmatrelvir is an oral antiviral that has been developed specifically for treating COVID-19. It is a protease inhibitor that inhibits the SARS-CoV-2 3CL protease, and it prevents antiviral replication. Ritonavir inhibits CYP3A mediated metabolism nirmatrelvir, and therefore increases the plasma concentration levels of nirmatrelvir to therapeutic levels. The dosing and usage. Participants.
This, Charlie, if you're happy for me to.
Yeah, absolutely. Yeah, sure, you go for it.
Just to introduce myself, my name's Ivy. I'm one of the PANORAMIC trial managers, and I'm overseeing safety for the trial. So in terms of dosing and usage, so participants who are randomised to usual care plus Paxlovid will take Paxlovid for 5 days. As Charlie mentioned earlier, there are 2 types of tablets clearly labelled in the participant packs. Nirmatrelvir must be taken with ritonavir to achieve therapeutic concentrations. The recommended dose for nirmatrelvir is 250 milligram tablets with 100 milligram ritonavir tablets. This should be taken orally twice a day for the 5-day duration, with or without food, swallowed whole, so not crushed. If a dose is missed within 8 hours of the time usually taken, the participant should take it as soon as possible and then resume the normal dosing schedule. If a dose is missed by more than 8 hours, the missed dose should not be taken and the next dose taken at the next scheduled time. So doses should not be doubled to make up for a missed dose. It's particularly important for participants to ensure they complete the medication course. If they do not, there is an increased risk of antiviral resistance developing. So this is just an excerpt, I believe, from the participant instructions with regards to dosing. I won't read it through, but it just gives them an example of how the dosing schedule could work for them in a typical day.
Thanks very much, Ivy. So what we're planning on doing is going through sort of a summary of what's going to change with the Paxlovid arm coming in. Something I should have mentioned at the beginning and didn't. Firstly, my name is Charlie Vickery. I am the trial manager in charge of recruitment. If you have questions during the presentation, please do pop them in the chat, and we'll pick them up at the Q&A session after we finish the presentation. So a quick summary of what's changed. There are additional eligibility criteria for those in the Paxlovid arm. Who can assess eligibility and randomise has changed for the Paxlovid arm and for the other arms as well. There are more safety calls that are going to be in the Paxlovid arm. There are going to be some changes to the CRFs coming up. There are going to be changes to working instructions coming up, and there are some non-Paxlovid related changes too. So the first thing to talk about is who can assess eligibility. For Paxlovid, only medically qualified clinicians with access to the patient's full primary care record can take eligibility and randomise to the Paxlovid arm. There are other bits that other staff can do. So, for example, completing the initial registration and completing some of the follow-up calls. But for the Paxlovid arm, only doctors can do that bit. The inclusion criteria have also changed. These inclusion criteria that we've listed here are in addition to those listed in the master protocol. So if you need a copy of the master protocol, please do put it in the chat, and we'll send round a list of those later on. So people who want to be in the Paxlovid arm need to be willing to take a pregnancy test after randomisation and prior to starting Paxlovid treatment. And patients with known mild kidney disease, so CKD stage 2, must have an EGFR measurement taken in the last 6 months. Additional exclusion criteria, in addition again to the master protocol, if they are known or they suspect that they are pregnant or they are breastfeeding, then they can't be in the Paxlovid arm. Participants of childbearing potential also need to be using suitable contraception. There's a big list here, but the biggest changes are hormonal contraception can now be used without the barrier method, and abstinence is now allowed, but it should be the patient should have been abstinent for at least 28 days before enrolling in the trial, and for at least 28 days after they are randomized, so during the follow-up period. And it should be in keeping with the participant's normal lifestyle as well. And just to note that the barrier method on its own is not sufficient to take part in the Paxlovid arm. So moving on, other exclusion criteria, a history of clinically significant hypertension to Paxlovid, patients with hereditary problems with galactose intolerance, total lactase deficiency, or glucose galactose malabsorption, patients with known current severe liver impairment, and then you've got a big list there of the particular conditions, patients with moderate or severe renal disease, so that's CKD stages 3, 4, and 5, or an acute current kidney injury. And they have an EGFR of less than 60 in the last 6 months. If they're currently taking Paxlovid, they can't take part, and if they are taking any of the drugs that we're about to talk about, then they can't take part in the Paxlovid arm either. And Ivy, I'll hand over to you for the drug section.
There are a number of potential drug interactions with Paxlovid, hence why there is a need for enhanced safety monitoring for this arm. There are some drugs that prevent inclusion in the study, and also some drugs that do not necessarily prevent inclusion, but may require extra precautions such as enhanced monitoring or self-monitoring. There is a list of drugs that would make participants ineligible or eligible, but with cautionary advisements. They can be found in the new version of the protocol in Appendix G. The SMPC is currently being reviewed on a monthly basis to ensure that we are providing you with the most current list of drugs. As soon as there is an update, we will of course also update the protocol and inform you of any changes. A list of drug classes that affect and the effect of Paxlovid on concentrations of those drugs can be found again in Appendix G, List B, along with other implications of trial eligibility. There is clinical judgment required to evaluate potential drug interactions. Advice can also be found on the Liverpool COVID-19 Drug Interactions Checker website with a handy link here.
Thanks, Ivy. So follow-up calls. There are additional safety follow-up calls to be made for those randomised to Paxlovid. These will take place on day 4 and day 10 post-randomisation, and they are to monitor any medication, any new medication that's been started, and to examine the side effect levels of Paxlovid participants. So all calls can be made by a suitably delegated member of staff, so it will be a nurse, a pharmacist, or a clinician. And calls will monitor the side effects will monitor side effects and CONMEDs in the Paxlovid arm. So the changes to medication are also monitored in the daily diary as well. And if the participant records starting a new medication, an automated alert gets sent to the safety team. So if the participant says, I'm taking a new medication, the safety team get pinged, and they will know about that. So just to go over what is currently happening compared to the arms that are currently active and Paxlovid. Molnupiravir has a safety call on day 1 and day 2. Paxlovid has a safety call day 1, day 2, day 4 and day 10. And usual care has a safety call on day 2. All of the arms have follow-up calls if they have not completed their diaries on day 7, 14 and 28. There are also going to be some changes to the CRFs as well. So on the registration form, the Paxlovid eligibility questions are going to be added in. And there will also be an e-sign-off for clinicians. So you'll have to enter your username and your password to confirm that someone is eligible to take part in the Paxlovid arm. The day 2 safety call, we removed the PCR test question. I'll come on to that a little bit later. Additional Paxlovid specific side effect questions have been added, and questions regarding drug interactions as well, only in the Paxlovid arm. There's 2 new CRFs, so day 4 and day 10 calls. They broadly mirror the day 2 call, but they've got a few other little bits in as well. And also the daily diary and day 7 follow-up CRFs have additional medication monitoring questions for the Paxlovid arm only. AE reporting. Ivy, do you want to take this one?
Yep. So unlike molnupiravir, as I mentioned before, because of the nature of Paxlovid, there is enhanced AE reporting. So all non-COVID related events will need to be reported as adverse events in order for us to centrally monitor side effects of Paxlovid. There are built-in questions in the call CRFs that will prompt you to ask about these symptoms. If any of these questions are completed, then there is an automated alert that will be sent to us centrally to let us know that this has been completed, and you will also be prompted to complete an adverse event form through the database.
Brilliant, thank you, Ivy. So in terms of practical changes and what's going to happen next, day 2, 4 and 10 safety calls will be done by hubs for participants recruited at hubs. These will include weekends and bank holidays if safety calls fall on them. So please do think about when you're going to be able to randomise participants and your capacity for that. Members of staff completing these calls should be appropriately delegated. They should have CVs, GCPs with us. They should be on the delegation log, and we should have a copy of that. And they will need all of that to have Spinnaker access anyway. But it should be a nurse, a pharmacist, or a clinician who's doing that. Once all the working instructions are finalised, we'll be circulating those to you. They've just got some final checks to do before they get sent out. Research nurses will not be able to check eligibility or to randomise to Paxlovid, so there's going to be a shift towards GPs doing some of that work. That doesn't mean that there will be no tasks for research nurses, so those initial contacts with patients and also the follow-up calls as well. And with the addition of the eligibility questions to the Paxlovid arm and the need to check the patient's medical notes, the eligibility for the Paxlovid arm is going to take a bit longer. So what's next? If you're interested in taking part in the Paxlovid arm and you haven't yet told us and you have capacity to do this, please email the Panoramic Trial inbox and let us know. My colleague Liz, who is on the call, who is in charge of the Panoramic sites, will be picking those up. If you haven't done so already, please review the most recent Panoramic protocol and the SPC for Paxlovid. The aim is to open the Paxlovid arm it does say in early April here, hopefully in the next week or two, and we will contact you to sort out green lighting you to Paxlovid arm if you've said that you want to take part. So just to pick up on a few other things that will affect hubs, the virology sub-study has now been added. This is only being recruited by the central team. It's just there's a lot of reference to it in patient information sheets and stuff like that. Don't worry about that. That's just for us that we're doing. As we discussed earlier, including the inclusion of participants using hormonal contraception without barrier methods or participants practicing abstention is now allowed for both molnupiravir and Paxlovid. Participants will now be able to be eligible to take part in the study with a positive LFT without a confirmatory PCR. So PCR testing is much lower than it was, whereas lateral flow testing is a bit more easily available. So people are going to be able to take part with just an LFT. Pharmacists are now able to consent, assess eligibility and randomise to lower risk interventions in PANORAMIC, so molnupiravir at the moment. And there are some changes to the protocol and the PIS reflecting the amendment. If you haven't had a look at those already, please do go and have a look. The final things we've included, there's a link to the Liverpool COVID-19 drugs interaction checker. I've also included here some of the sources that we've used in the Paxlovid arm if anyone wants to go and have a look at those, if people are interested. And the SPC is the last link down the bottom here. I've also included a slide with our contact details. So if you need to get in touch with us, these are the ways of doing so. Please let us know if you want to take part. We really appreciate it. Thank you all very much for taking part. Hopefully we will now have some questions.
Charles, hi there. Can I just introduce myself, if that's all right? So
yes, absolutely.
Hi everyone, my name's Naj Rahman, so I'm Professor of Respiratory Medicine here in Oxford and lead ORTU, which is also leading on the safety aspect. So if you have any safety questions, etc., then do please shout out and put it in the chat. I think one thing that's very clear about Paxlovid is this is going to be possible with this team, but it's going to be more complex than molnupiravir, and it's good to accept that up front. We're going to have a lot more stuff reported from the safety perspective, but that's the whole purpose, because we were much less worried about molnupiravir, let's say it that way around, and we are likely to report much more in terms of adverse events. And so it is more complex. I don't think the recruitment will be as fast because it's much more restrictive. And I would imagine that people doing the day 4 and the day 10 safety calls may quite often need to ring the on-call person who's holding the safety phone, and that's perfectly fine, and we've built that in. So I just want to reassure you that that's the way around we hope it to work. I think there'll be a learning curve as we move forward, but yeah, happy to take any specific medical questions.
Thanks, Naj, much appreciated. I can see Dave Lewis has his hand raised. Dave, do you want to?
Yeah, so it's not a medical question, but if we do sign up to it, which I think we'll have to think about, is it possible to choose for some patients not to even think about Paxlovid? Because we've got 2 different sources of patients, some of whom we have access to their medical record and some of whom we don't. So obviously, for the ones we don't, we can't even think about Paxlovid. So will we have a way to say yes or no to Paxlovid before we start for that individual?
So I've just thought of a way off the top of my head that you might be able to do it. There is an option to say, there is a question that says, is there any other reason you wouldn't randomise this patient to Paxlovid? You can tick yes on that. However, I need to double check whether that's with the senior management, whether that's an acceptable way of doing it. What I'll do is when I circulate these slides, I will include the answer to that question in there, if that's okay, Dave.
That's fine. I mean, the difficulty will be because it's so doctor heavy, we won't be able to do this every day, even for the patients where we do have access to the records. So I mean, it's almost feeling like it would be simpler for us just to say we won't do it. Do you know what I mean? Because we have nurses who can call, but if they've got to go into the Paxlovid arm and they're not really allowed there anyway, then do you know what I mean? It may become just too complicated for us to do it like that. That depends how you set it up.
I think that is. No, you look like you wanted to come in there.
Can I just come in, David? So I think you're making a very valuable point, David. The way that I understand this is you have to have a combination of a doctor and a medical record to get them into the Paxlovid study. And what you're describing is a pragmatic problem that I completely understand. We would like hubs and practices to say yes, understanding that on a Tuesday, those two things may not be present, in which case you just randomize to the Molyneux arm and that's not a problem or usual care. So, but in order to get anywhere near Paxlovid, there must be a GP or a medically qualified clinician plus the medical record. And in your expertise of your area, if you feel that person or that record is not present on a Thursday, then you can't randomize on Thursday. I think Charles will and Ivy and I will need to take this back to the data folk and try to get a workflow that gets you there. But we would like you to recruit on the days that you can, accepting that it won't be every day.
Yeah. So okay. in terms of switching you on and off, it's fairly straightforward. My immediate concern is what happens if something goes wrong in that chain. We do have our operations meeting immediately after this meeting, so we'll discuss it then, and we'll try and bring you an answer back today if that's okay.
Yeah, that's great. I mean, ideally we'd be able to switch it off ourselves at the start of the process, and that would be safer and simpler. You know, the nurses could say, Paxlovid not an option today, just do molnupiravir. I think that would be easier for us.
I don't think that's possible on the database. Okay. With the way the database is set up, there's certain admin privileges that you need to have, and I don't think that our database team would be happy for a clinician to have that, because you can then edit a load of other stuff as well, and it's really sort of back end stuff. So I think we'd prefer if people didn't have access to that. Sebastian, you have a hand up as well. Thank you, Dave.
Questions, if that's okay. So one, is the funding the same for Paxlovid as molnupiravir?
That is a very good question. I need to double check on that. Sorry, I'm not doing very well with answering your questions so far today.
Yes, it'd be good to know that soon if we could, and would be handy. The searches that we've got for the Paxlovid, will they exclude anyone who's on a medication that would preclude them taking Paxlovid anyway?
I believe not. No.
Could they?
Nick Thomas has just answered your first question. Nick, do you want to go ahead and?
Yeah, I do mean to come in, Charlie. That's fine. Sorry. Hi guys. So Nick Thomas, I'm the CRN lead for Thames Valley and South Midlands, and I'm clinical lead for research at the RCGP. Hi there. So I'm part of the TMG as well as Nadges and several others on this call. So yeah, the costings are going to be higher, Sebastian, definitely. I think they're still waiting agreement at the moment officially for Mark Dolman, who is the deputy coup at Thames Valley and is trying to get those finalised at the moment. But I'd expect them to be almost. What's the costing at the moment? About 120, 130 £, I think it is. Is it per for molnupiravir? I think it's almost double that for Paxlovid, or maybe 1.8 that, somewhere around there. I think that's the ballpark area, made up of research and service support costs, obviously as a mix. But we're not quite. I think they're not quite in stone yet, which is why there's delay. And the delay is mainly around the patient searching and the spoke activity that we've got going on now. And I think they're trying to really work out how that can be costed appropriately going forward. My other thought was, David, what you said about the half and half thing with the spokes and the hubs. So I'm a hub and spoke, so I've got a hub site, but I've got spokes around me where I can't see the full medical record. I won't be able to recruit from those spokes. So ultimately they will just stop. That's what's going to happen, I think, unless we can get past the full medical record thing, whether I get full EMIS and not data share yet, and confidentiality agreements in place to allow me to then allow the hub to look at that full medical record. but that at the moment won't be happening at my side. Therefore, that's my local problem. So I'm dealing with that one. And I think, Sebastian, what was your other question? Was it around? Sorry, I've forgotten. There was another third question, wasn't there? No.
So so it says in the protocol if they've got CKD stage 2 diagnosed, then they they'd need to have had a GFR done within 6 months. So I guess, total honesty, we wouldn't generally diagnose CKD stage 2, so we wouldn't know they had it, and therefore we wouldn't have rechecked in the last 6 months. Is that a kind of a reasonable approach, that we don't know they've got it, therefore they don't have it, and therefore
Yes.
go ahead and do it?
Brad, I assume Nad, you agree with that one, because I think that's if they don't have a diagnosis and you've done a full medical notes review, then therefore you can proceed to randomise, can't you?
Yeah. So and I agree with that. And Sebastian, thanks for the question. The CKD stage 2 is a threshold, right? So it means that if they're stage 4, we kind of know about that and we would know. So stage 2, don't know, don't tell, is absolutely fine. So you don't need to go looking for it, because this is a pragmatic in the community study. We can't do massive blood screening beforehand. Charles, may I just answer a couple of the previous questions that have been in the chat just very quickly?
Yes, please do.
Ivor Singh's asked several important questions. One of them is, can you continue with molnupiravir in usual care? Yes, for the period that molnupiravir continues. And of course, at some point, we will have a result and stop recruiting to that arm. So yes, of course, if they're not recruiting. There was a question about the ratio randomization 1:1:1. We've designed this so that if they're eligible for molnu and usual care, that's 1:1. If they're eligible for all three, it's 1:1:1. So there's an internal control for that. And then a really important question about the usual care arm. Are we going to drop it? Not unless the molnupiravir arm shows great positivity, in which case molnupiravir becomes the usual care arm. So unless we have that at scale data, which we might have soon, that molnupiravir is better than standard care, usual care will continue. And I do understand the difficulties of randomizing upset patients because they didn't get the magic drugs. I get that. But you guys as a team have done that successfully for 20,000 patients. Okay, that's all. I think that was all the big questions that I picked up on. Happy to answer any further ones. Or Charles, anything else?
Nothing else from me. I think if anyone has any other questions, please do pop them in the chat now. Or raise your hand. Yeah, that's fine. Antoinette.
Hi, Charlie, thanks. One of the things that I did put in the chat and it wasn't picked up, it was around the actual search. So I think it was Sebastian was just asking about whether or not things would be excluded. So, for example, COPD. So with the standard molnupiravir arm, the search is actually quite wide and far-fetching. But when we introduce Paxlovid, obviously there are lots of other inclusions and exclusions. So they're not going to be included at that time. So for people like us that are actually would be able to do a search and a message out and contact those patients, not using the platform, how would that work? Because effectively we're opening it up to a huge cohort, but potentially most of them wouldn't be eligible when they then are screened because of the whole host of inclusion exclusion for Paxlovid.
Sorry, I think so. What you're trying to understand is you want a search. That's
So ideally, I mean, it would be absolutely fantastic if we knew this was the search that gleaned 10 patients out of. We do a search and we could have 180 patients a day for molnupiravir, but out of that, there would only be a very small number that if you ran that search, that would be equivalent for those potentially eligible for Paxlovid. So for us, and obviously for clinician input, that would give us a better feasibility. But what I've understood is the search is actually going to remain the same, but the inclusion exclusion then has to be administered to actually finalise those who would potentially be eligible for Paxlovid.
Yeah, so in terms of like how that will actually work, so I actually got a glimpse of the database yesterday after our first meeting. So I'm actually a bit more equipped to answer this question than I was yesterday. What will happen is they go through the you go through the eligibility questionnaire. If you've answered the Paxlovid questions, sort of the patient is not eligible for Paxlovid, it will only give you the options to randomize to molnupiravir or usual care. So the patient can still go into those two arms, but they can still go into the two open arms. They just can't go into the Paxlovid arm. So you will be able to screen those big lists of people, but some of those people will be eligible for molnupiravir and some will be eligible for molnupiravir and Paxlovid. Does that?
Yeah, no, but I think
does that work it out a bit better?
I completely appreciate what you're saying.
If you want to search, I can take that back to the ops meeting and discuss it.
Brilliant, because I think moving forward, molnupiravir is going to, and all the indications are, it is going to scale down. So a lot of people will be focusing on the Paxlovid. So actually, why not be able to run a separate search for the Paxlovid? And we know they're the ones that we need that clinical input on. Yeah,
and I suspect if that is going to be the case, it would be more pressing to the TMG the closer we get to molnupiravir closing. Naz, do you agree? Do you broadly agree with that?
Yeah, so Anton, I think it's a brilliant question, and the ideal thing would be, let's search for Paxlo patients, let's search for molnu patients. I'd like you to understand that Paxlo are a subset of potential molnu patients. It's that way round.
Yeah, no, I appreciate that. Yeah,
absolutely. And so at the minute, we have to do the big search and then exclude. Hopefully, as soon as the first exclusion comes along, they just drop straight into the molnu usual care arm. To Charles's point, if molnu closes, and I suspect it will fairly soon, then we can then say, well, let's now have an aggressive Paxlo search to stop wasting your time. So I'm sure we can build that in as time goes forward. Yeah.
No, absolutely, and that's a really good idea, because some of our lists are huge on a daily basis, and actually the resources to actually call each one of those, yes, and then to find the holy grail of the Paxlovid potentials and agreeing is difficult. But yeah, as long as it's been looked at, that's great. Thanks.
Yeah. So just to cover some of the questions that are just coming up in the chat, I'm just going to come to people with their hand raised in a minute. So Paxlovid is going to be randomised 1:1:1 with molnupiravir and usual care until molnupiravir closes, and then it will go down to 1:1, is my understanding. Can we request nurse colleagues do the initial sign up if molnupiravir and then they randomise? Yes, so you can absolutely do that. They can do the initial sign up. If they're then going to be eligible for Paxlovid, you can then get a clinician to come and take that over as well. The practicalities of that might be tricky, but let's see how we go. Either in terms of how the flow will work with 100 odd patients per day, Naj, do you think that it would be accurate to say that we're expecting a bit of a drop off in recruitment?
I think we'll definitely have a drop off of recruitment, Charles, because if you look at the proportion of recruitment from where they've come, a great majority of those in molnu, we just can't do it that way because we haven't had the correct eligibility check in place for Paxlovid. So I think the numbers will be smaller. I may be wrong, and if I was wrong, I'd be happy to be wrong, because that would mean we're recruiting well. The flip side is we're not expecting this to just look like molnu. This is not molnu number 2. This is a different drug with a different set of challenges, and we accept that there is likely to be slower recruitment, and there's a lot more work to do here as well, isn't there? More safety calls, etc., etc. So I think it's suitable if the brakes are applied a little bit. Yeah.
Yeah. And then Ivor, just your final comment. No, the central team are not recruiting people to Paxlovid because we don't have access to people's medical records. Chris, I'm going to come to your question in a minute. Can I just, who's got their hand raised? Steve, is that a previous hand or is that a new hand?
No, current hand. Thank you very much. Thank you very much. Two questions. Sorry, I'm getting some feedback. Can you hear all right that end? So just to reiterate Antoinette's point, I think it would be really useful to have that subset search available. I think just looking through the list of contraindications and interactions, I think anything that helps us to do it more safely would be helpful. And also in terms of planning, because we've got to get doctors available to do the recruitment. If we know how many are for different arms, it would just help with our planning for the day to try and get people in as soon as possible. The other question was just going back to the CKD3 thing, Naj. One of the challenges here is sometimes you'll have patients on the borderline of CKD3 who've had a previous low EGFR, And what do we do in that situation? Their most recent EGFR is more than 60. Is that acceptable? And they've not been coded as CKD3.
Yeah, so thanks for the question, Steve. I mean, look, I think we should be pragmatic. One of the important parts of this study is whatever result we get, it will need to be applied in the real world when these conversations happen. So we need to balance that with the safety aspects. The situation you've described, I'd be happy with that patient going into the study, absolutely. And okay, there's going to be a bit of agnosticism here where we go, well, we haven't done it for 6 months, but prior to that it was etc. And then that's fine. So I'd be very pragmatic. And look, we're always on the end of a phone to have a discussion with recruitment or after. Yeah.
Yeah. Oh, and just one other thing, is it possible to have the list of interactions put into EMIS, or will they be in EMIS? Do we know, so that when we adding the drug in,
yeah.
Again, my worry is that I'm going to miss something when I'm looking through, and just to make it as safe as we possibly can do.
So Charles, I don't know the answer to that. I don't have any expertise in EMIS myself, I'm afraid. Do you know? Oh, you're mute, I'm afraid.
You think
someone has to do it once, right?
I literally did this yesterday as well. Yesterday in the meeting as well. I started talking and realised I wasn't on mute. After 2 years, I still haven't managed it. So there are definitely ways of putting sort of pop-ups in EMIS that would say whether someone is eligible or not, and sort of running a search based on that. Again, that's probably one that I will take. So Nick Thomas, who unfortunately has dropped off this call and would be able to answer the question.
Sorry, Charles, it's not that. It's the point is that, so when we put in any other drug, the EMIS prescribing will show the drug interactions. So I guess what I'm wondering here is, will Paxlovid be populated in EMIS as a drug that will check for interactions, so patients are on a drug? So it's a safety thing, not a recruitment thing.
I don't know the answer to that, but I can certainly take it to a clinician who will know the answer to that and get you an answer.
Can I just say, I'm Nick from Newquay. I don't think you can do that on EMIS. I'm pretty sure you can't, unless Paxlovid is in the medication list in EMIS, then, and all the interactional data with it probably won't. That makes sense.
I think it does. I'm looking at it now, and it seems to work.
I mean, it is prescribable for HIV, etc. right now. So
it works. It comes up with all the interactions with a given patient.
Oh, there we go. That should be all right then. That should be okay.
That's fine, yeah.
Just going back to Chris's question, any news on LFTs? We are in the process of trying to get some. It's now the mechanics of how we get lateral flow tests out to our hubs. So I believe it is in the works, but I can't give you any more information than that yet because we haven't sorted out a few of those bits yet. Either some patients may not have had an EGFR done in the last 6 months. One of the inclusion criteria is that they have had one done in the last 6 months, so they will have had to have had that done if they're CKD stage 2. Yeah. And therefore would be eligible.
Just to be clear, Charles, if they're not known to be CKD, there's no need to go looking. So just to be really clear about that.
Great, thanks, Naj. Any thought on asking the local A&E departments, staff testing for NHS staff acting as PICs for primary care hubs? Again, certainly something I can take back. I'm just going to copy that and stick that in my questions list for the ops meeting. Emma Barber, will there be a direct line we can use to discuss recruitment? There'll be occasions when we'll need to get an answer immediately and it's been difficult to speak to someone. Our switchboards have been rather full during the Molnupiravir period. We've been getting over sort of 1,000 calls a day incoming. I will take that back and see if we can have a separate phone network that can be just for you guys calling in. If that's okay, let me just put that on my list.
There was also, sorry.
Melissa, you're going to say, go ahead, yeah.
I was probably going to say the same thing as you, just to remind clinicians that there is the safety line, a specific number which will get you to whoever the clinician on call is with the central team on that day. We have got a clinical safety monitor joining the team soon, but in the meantime there's a rota of clinicians, so we can make sure that you have that number for any of these specific clinical eligibility calls.
And I think, can I just input on that as well? I think we'd prefer, I'm one of the clinicians on that line, we would prefer a phone call than an email or a WhatsApp message, because it makes it very immediate, and hopefully you would immediately get an answer as well. That phone number is widely available, yeah.
Okay, that's great. Are there any other questions? I think there's sort of stuff going on in the chat, but it's not necessary. It's sort of discussion between clinicians at the moment. So I think if that's the case, if you have any further questions, do feel free to email us at the Panoramic inbox. If it's a safety question, go to the safety email. If it's a general day-to-day running of the study question, please come to the main study inbox and we'll try and pick that up for you. Thank you all so much for joining, and Naj, thank you very much for coming along and answering questions as well. It's really, really appreciated, and Melissa too. Brilliant, lovely to see you all, and look forward to hearing back from you about whether you can do Paxlovid. If you haven't already, let us know.
Right, well done,
thanks very much.
Bye now.
Bye.
Thank you.